Today I'm going to discuss the ins and outs of specific EHR databases. My disclosures are shown on this slide, none of which are relevant to this presentation. I have previously presented and published on clinical practice outcomes in neovascular AMD, DME, and RVO-associated macular edema. I am very excited about the potential for real-world data in ophthalmology. Today I'll briefly cover why is real-world data important, claims data versus EHR data, common current databases, conversion of Snellen visual acuity, and limitations of EHR database clinical research. Given the ability to scale, real-world data is important for numerous applications, including natural history studies, benchmarking for practice improvement, as well as clinician and therapeutic value-based care, clinical research including retrospective studies, clinical trial site selection, and patient identification, and finally, as providing commercial insights to optimize portfolio allocation and launch strategy. While claims data may be well-structured, EHR data provides important clinical nuances and details. EHR data is generally rich with history, exam findings, and treatment details. The IRIS registry is the nation's first comprehensive eye disease clinical registry. All U.S. ophthalmologist academy members in good standing are eligible to participate in the IRIS registry. These physicians benefit because the system facilitates quality measure reporting for Medicare's merit-based incentive payment system. The IRIS registry includes 79 million unique patients and 571 million patient visits. Verana Health provides analysis of the data in various data-driven products, such as clinical trial site selection and patient identification, as well as insights for industry. Available data includes patient history, exam findings including visual acuity and intraocular pressure, as well as diagnosis. Unfortunately, there is limited ability to query imaging. Another EHR-based database is the Corvitas Vestrum Health Retina database. It includes 2.3 million unique patients and 15 million patient visits from U.S. retina physicians. Importantly, as a retina specialist database, it differs from the IRIS registry, which instead includes all specialties. The Corvitas Vestrum Health Retina database includes a panel of over 350 U.S. retina physicians. It is geographically diverse, and like the IRIS registry, available data includes patient history, exam findings including visual acuity and intraocular pressure, as well as diagnosis. Once again, there's limited ability to query imaging. These EHR-based systems de-identify data and aggregate it in a HIPAA-compliant, secure fashion. Like the IRIS registry Verana Health system, the Corvitas Vestrum Health system provides various data-driven products such as clinical trial site selection and patient identification, as well as insights for industry. Recently, Retina Consultants of America and Retina AI announced a collaboration to develop a real-world evidence US-based database. So far, there have been over 1.7 million annual patient visits in over 200 locations. The formula shown here was used to convert Snellen visual acuity into an ETDRS approximation, but this obviously can't compare to a standardized ETDRS protocol refraction. Finally, I want to point out that clinical research using EHR databases has multiple limitations. These studies are retrospective with limited controls, which cannot be compared with randomized clinical trials. Furthermore, there's limited ability to tailor inclusion and exclusion criteria compared to the explicit criteria in randomized controlled trials. We've already discussed the non-standardized visual acuity assessment, and imaging is generally non-standardized with limited ability to query that image data. Today we covered some important concepts in EHR-based real-world databases. While there are limitations, given the ability to scale, real-world data is important for natural history studies, benchmarking, clinical research, and commercial insights. Thank you very much for your attention today.